Hello, my name is Mike Kelly, psychiatric nurse practitioner and DNP student at Brandon University, and this is my stakeholder education plan video. This is a 5 to 10 minute video that provides a description of the stakeholders, their roles, education needs, a theoretical foundation for the PICO intervention, and an outline plan to carry out the intervention. Stakeholders include, first, psychiatrists. They have an administrative and financial role. They have 5 collaborative partners that take turns working at the clinic. Second, nurse practitioners. They carry a clinical role, same role as I, covering patients with the intervention. Educational needs for both psychiatrists and nurse practitioners will be an in-depth awareness of the actual intervention, the implementation process, expectations, and how to record the data. The third stakeholder are therapists. They hold a clinical role. They see patients that I have been seeing that have been provided the intervention. Their education on this is not required because they will not be encouraging or promoting the intervention. Last, the fourth stakeholder are office staff, our management. They hold a clinical role. They schedule patients and are responsible for bringing patients with the interventions back to me, making sure that they follow up, and indicating to other covering providers that the patient is mine and to follow the procedure as explained. So I would like to, at this point, discuss the theoretical foundation and conceptual framework for my PICO intervention. The clinical problem is non-adherence in the outpatient setting with psychotropic medications such as antidepressants, mood stabilizers, and antipsychotics. According to Bullock and Patton, 2010, a systematic review averaged 50% non-adherence with psychotropics. Personal clinic experience in the last year in review of the literature and document SOAP notes displayed a 25 to 35% range of non-adherence rate for medications due to side effects such as increased depression, sexual dysfunction, forgetfulness, misinformation, unclear expectations, complex dosing, and major gaps in pharmacoeducation. The population consists of private and state reimbursed individuals with a wide range of sociodemographic variables. Non-adherence to medication regimen increases the need for follow-up appointments, symptoms, it increases financial burden, and creates a poor quality of life. According to Anderson et al. 2010, non-adherence creates symptom relapse, hospitalization, poor quality of life, and increases morbidity. Therefore, a substantial portion of the initial and follow-up appointment needs to be spent on pharmacoeducation, and doing this can dramatically reduce non-adherence rates. Systematic research discovered the lack of pharmacoeducation might have contributed to 68.3% non-adherence rates among children and teenagers. Next is I will provide the outline for delivering the intervention. So, an educational intervention will be implemented to improve psychotropic adherence. The goal is to improve quality of life and pharmacologically manage symptoms over time. The pharmacoeducation will be consistent in terms of structure and delivery, and it will include education on expected outcomes, anticipated side effects, and long-term adherence outcomes. Expected outcomes include specific symptom relief and a timeline for medication reaching efficacy. Anticipated, temporary, and long-term side effect education will prepare the patient, therefore reducing fear and strengthening adherence. To target forgetfulness, SMS short messaging is performed with the MediReminder app. This will also introduce innovative intervention into the PICO question. Long-term adherence education will introduce probable outcomes throughout the year and at 2-month intervals. This education will create long-term focus and realistic management of symptoms. Data will be extracted from each patient during the initial and follow-up visit. The data will be entered onto a Microsoft Excel spreadsheet document that reflects either adherence or non-adherence. The data will be demographically categorized and include sex, education level, diagnosis, and age. 6 months of pharmacoeducation intervention will provide a benchmark which will be retrospectively compared with a similar population at the same clinic who did not receive the intervention. Again, psychiatrists covering the intervention and nurse practitioners will document, and the data will be extracted by myself the following day. So, communicating value and progress to stakeholders. Collaborative psychiatrists will meet monthly to discuss the process and improve facilitation of the intervention and discuss its value. Nurse practitioners will be that cover my patients that initially that were provided the intervention will meet monthly with myself as well, and we'll review the intervention, provide them the value for this so they can reinforce it in their practice. Therapists will just be encouraged, will be taught the value of the intervention, the value of medication, and encourage the patient to adhere if need be, but the intervention will not be reinforced by therapists. Office staff will also be given the value of the intervention and adherence to medication to reinforce having the patient follow up and adhere to a good follow-up appointment. So that is my education plan video. Again, this is Mike Kelly. Thank you very much.